introducing Luke Profitt. It's always such a gives you a warm, fuzzy feeling in your heart when it's one of your students that you're introducing. Even though Luke is now one of my colleagues. So Luke's a family physician and a senior lecturer in our department. He works at the Friedenberg site and he's been teaching there for the last 2 years. He graduated with his MEd and his FCFP last year. And as you will see from his talk today, he's got special interest in access to care, which is a function of the quality of care provided across the life spectrum. And since he's been working in Friedenberg, he's been very involved in strengthening the health services and teaching students. Luke's a cyclist. Apparently, he's a mean board player. So I hand you over to Luke Profitt, who is on the call, but is to this point remained anonymous. Luke, put it.
Thank you, Taslim. Thank you for the welcome. So I'm going to be presenting on my master's work, as Taslim has already said, looking at barriers to accessing healthcare in children. And so I'm going to share my screen so that you can see the presentation I've made.
Sorry, Luke, I'm just giving you access rights. 1 minute.
Thank you.
There we go. Should work now.
Aha. Can you now see my screen?
Yep, we can see.
Okay, let me try and figure out things in presentation mode. Okay, so the title of the study that we did, we entitled it Healthcare Access for Children in a Low-Income Area in Cape Town. It was a mixed methods case study, and a couple of you on the call were directly involved and have heard at various times about this study. So particularly thanks to those who have assisted me and co-authored with me, Ben van Stormbroek, Graham Brezik, Liesl Rousseau, Taslim Russ, and Klaus van Presenten all had a hand in eventually getting this published. And it was published in December in the South African Family Practice Journal. For me, research begins with a story. And so the story started sort of as a registrar on call in the emergency department at False Bay Hospital. And parents arrived with a child who was already dead. And we can ask the question, why does this happen? Why does a child arrive at the hospital door already dead? And from a story, you start developing a theory, a hypothesis. Does it happen because there are barriers to accessing care? Can we interview parents? Can we look? Can we hear? Is this a single case, or is this the norm? And so within the setting of the False Bay Hospital drainage area, which is referred to as those there as the far south, that part of Cape Town that those who cycle the Argus would be familiar with as they leave the more built-up areas and go around the point, over Red Hill, and then back towards going towards Cape Town. This area that drains into False Bay Hospital includes Masiphumelele, it includes Fishhook, Capricorn, it includes Ocean View, there's Kommetjie, and then there are smaller areas, Glencairn, Simonstown, and Red Hill. False Bay Hospital is a district hospital within the Metro of Cape Town. It has 76 beds, and the 6 of which are allocated as inpatient beds for pediatric care. They work closely with a non-governmental organization who are involved in the community and helping the community health workers. So our study had 3 methods. The first was a quantitative survey. So we surveyed people in the community to ask, do people experience barriers for accessing healthcare for children? We conducted interviews with parents and caregivers whose children had been triaged either as a red code or a blue code, according to the South African triage score. And the third aspect of our study was that we did a nominal group technique with healthcare workers, which included community health workers, it included nursing staff, medical doctors, and we...
Hello, how are you? Good, Britt, nice to see you.
Doing well. Let's see.
So we were asking the question as to whether or what the possible solutions were then for the barriers that we found within method 1 and 2, the quantitative survey and the interviews. So as part of our survey aspect, we did 62 surveys, which was the number that we had powered to give us what we thought would be good results. And so we see that 74% of people acknowledged experiencing barriers in accessing care. And health-seeking behavior on the whole was seen as poor. It was either we rush off to hospital with the first sniff or sign of snot, or we do nothing until it's too late. And different people experienced different barriers with waiting times, barriers of the attitude of the staff, transport issues, language issues, a knowledge of the healthcare system, fears, and costs related to accessing care. The interviews that we conducted, it was by the vast majority the mothers of the children, but there were 2 fathers also in the 11 that we interviewed. And there were different reasons why their children had come to hospital, and there were different outcomes of their attendance at hospital. So if you look at this table that summarizes the demographic of the children whose parents we interviewed, you can see that there were 2 that were dead on arrival. Some were discharged home. Some were admitted at the district hospital, and some were transferred through to specialist care. We analyzed the interviews with a thematic analysis, and we looked at issues of accessibility and availability of care. And the quotes really point to yeah, these barriers of the cost of accessing care, which is more than just the physical money you must pay. It's the cost of lost days of work. It's the cost of physical access. And we had asked some of these same sort of questions within the survey of the community. And it's interesting to note that particularly certain people, like people who are foreigners, people who've come from Malawi, they tend to have to hire a vehicle to get themselves or their children to hospital, usually at a cost of about 500 Rand for the 6 or 7 kilometers journey. But some people don't even really know the ambulance number. One respondent said, well, we called the Uber. Someone else said, well, we know the number for the American ambulance service, but we don't know the number for our ambulance service. And people reported it being far. One person reported that it's difficult to access care at the clinic because of safety issues. And then one of the other themes that came up was the acceptability of the health service. And it really forms a barrier in people's minds. People see or express about our work ethic within the health services. They express opinions about our attitudes and about the waiting times. And so there are quotes that say, well, you can't speak to them. You can't speak to the staff. They're irritated. They're trying to show me. They tried to do something, but they're not doing something. How do we break bad news? How do we get the staff that are not healthcare workers to help our patients? One mum reported asking the security to help her and her child because she said the child was getting dizzy, but the security ignored them. Another said, he almost died. They didn't care about it. And someone put it quite succinctly saying, I think they're not trained well enough to engage themselves in the lives of people that come. They say, you wait forever. And sometimes people are turned away because they just don't have the capacity to deal with you today. The thing is, people experience our healthcare system and it makes them have difficulty in accessing it the next time. There's issues with parents sitting for a long time, the children being hungry. But there are also knowledge issues. Parents don't know. So one child had taken toxins, and the mother reported, oh, his daddy stopped him and washed his mouth out with soap. And just a basic lack of knowledge for how to treat and manage basic illnesses. There's knowledge of our healthcare system, and particularly expressed by those who come from outside, who are not South Africans. But even if the parent or caregiver knows how to treat their child, they might not be able to do so because the child is in the care of someone else. But some people also have positive influences. There's someone they work for, someone that they can turn to. And these sort of people facilitate access. So for those of you who don't know, nominal group technique is a technique used to gain consensus and rank that consensus, kind of similar to a Delphi technique, and you kind of go around in a circle. These are the ideas. Let's group the ideas, and let's put these together as ideas for how we can help, how we can modulate these problems that we've found, problems with accessing healthcare, the accessibility, the access to the physical access, the geographical access, the cost barriers, the financial access, the acceptability. How can we change and improve these? And so solutions were promoted by the group, which, as I've said, has included community health workers, doctors, nurses, and other interested people within the wider COPC arrangement within the False Bay Hospital area. Unfortunately, the emergency medical services representative who usually joined the group was not able to on the day that we did the study. But the rankings then that you see, so where I've put it in bold, those are the things that many people said, yes, this is something that we can do, and it should be easy enough to do. It's doable, it's achievable, and it will make a big difference. And so we have things like saying, well, let's improve access to emergency care by strengthening the state and private sector ambulance services and their relationship. Let's work on relationship strengthening in terms of how people relate, how healthcare workers relate to their communities. Is it possible to have emergency services at places that are closer than the only 24-hour facility? Could there be emergency services available that people could access at the fire station or the police station? Could an 8-hour CDC facility be changed into a 24-hour facility, or at least give them longer hours, so that the proximity of care is closer to where people live for emergency care? What about simple interventions? Simple things like putting a sticker in every Road to Healthcare book with the number of the ambulance. And within perinatal and antenatal care, identifying those who are at high risk, not high risk of obstetric complications, but those at high risk in terms of their children will be at high risk for social issues. And an early referral through to the community health workers to walk them through the first 1,000 days, educating them on breastfeeding, substance use, etc. How do we empower moms to care for their kids in such a way that they would be able to not just present when the kid is dying or has already died, but that they would be able to recognize at what level of illness do they need to attend healthcare? And so as part of this, we then made a set of recommendations. The recommendations basically is what we are already trying to do in terms of a whole of society approach. But we recommended looking at affordability
Is it just, I think we've lost Luke.
Yeah.
I think I've come back now. My apologies.
Okay.
I don't know what happened to
great.
my internet.
I'll come back.
Can you
Luke.
still see my screen?
We see
Yes,
the
we can still see it.
recommendation slide.
Okay, so we were talking about recommendations and talking about how to influence the affordability, the accessibility, the access to healthcare. It's things like crime reduction, improving translation services, improving the social capital. Who can people go to when they're struggling and they're not sure, do I need to take this child to hospital or not? We've talked about adjusting clinic hours. One of our strong recommendations was to increase the number of community health workers. There are multiple functions that they're asked to do, but if their numbers could be improved, health promotion could also be improved. And household and facility factors. Is it possible, as we've said already, to publish the ambulance number? And so while we have recommendations, I suppose there is more work that is still needed. How do we bridge the gap between these recommendations that we have and the financial constraints that we face as a Department of Health? How do we bridge the gap between wanting to reduce costs for patients attending, but needing to recuperate costs of providing healthcare? And how do we, this is just, I suppose, a snapshot from one sub-district within the greater Cape Town area, and not even a whole sub-district at that. So how do we then take this forward? And while I don't have good answers necessarily, I think it is still a useful study in terms of getting people like yourselves to look at and think about what is happening in your place, what's happening in your area. So yeah, I think it's I think the study then, it opens up an interesting conversation about how do we move forward. It's a medical discussion, but it's also a public health discussion. It's a medical discussion, but it's also, as we said already, a whole of society discussion. It's an education thing, but it's also a justice and a policing thing, and it's an economic thing. And so, yeah, I would encourage you, if you haven't already, to read the study. I think it's got a bit more detail in it than I was able to share now. But if you have specific questions, I think now would probably be a good time to ask those, or to, yeah, give comment. Yeah.
Thanks, Luke. A really, really important topic, and really appreciate the way in which you've looked at it in such a deep, qualitative way. I think you've posed a fairly fairly good questions in terms of conversation starters. So maybe we should start there and ask, are there any comments around any aspects of your presentation, or maybe in response to some of those provocative questions you've asked? Dave?
Yeah, thanks, Luke. That's great. Thanks, Taslim. Did you engage at all directly with the community-based services, with the NPOs? Were you able to? So you spoke to the individual families. Were you able to connect at all with the CBS workers?
Yes. So part of the nominal group technique method aspect of the research that we did engaged with community health workers. So we had, I had engaged with them prior to the formal sort of research engagement, but we did, have engagement with community health workers in both Masiphumelele and Ocean View, and got their thoughts and ideas and opinions even before we sort of dived into the research. But yes, we definitely did engage with them and fed back our information to them to help try and strengthen what they already do.
And had any of the people you interviewed, had they had a home visit? Had they been supported by CBS, or that didn't come through strongly in the interviews?
It didn't really come through strongly in the interviews. Different people told their stories differently, but it didn't really come through strongly that we had been supported by community health workers, or we know who our community health worker is. We asked them as a first point of call. That didn't sort of come through. People were like, we didn't know what to do. We didn't know who to call. We have heard of the security company ADT, so we called them. They said we should call an ambulance. We didn't know the number for the ambulance. It was,
because you would imagine if you were asking people about their access to healthcare services, and there were a deeply penetrated net into the communities, that should have cropped up a lot. They should have kept saying, all the people that they should have all mentioned something. But anyway,
but it didn't come up. So
to me, it's very telling.
Yes. So it's difficult to give judgment on the negative or the lack of information. I agree with you that I think it is somewhat telling, and that's, I think, one of many reasons why it forms part of our recommendations to increase the numbers and decrease the workload of the community health workers, in the sense that let them have fewer homes that they visit more frequently, rather than many homes, so that people within the community can know, this is my community health worker. There is also an intervention happening within Ocean View where young people are being trained up in first aid. So there's this whole EFAR system that's happening that I then allude to within the study and the recommendations. But yeah, there are hopefully many solutions to the problem.
Yeah. Thanks, Dave. A very insightful question, and the role of community workers in emergencies or identifying at risk. I recognize Samantha as the next questioner, and then I will go to Leonard, who's put something in the chat, and then there's someone else with a raised hand, who Steve Reed. Okay. So Steve, we'll come to you after Leonard's question. Samantha?
Hi, Luke. Thanks so much for that. That was really great. I'm definitely going to go have a read. I just wanted to ask, now in our current climate, with most of from what I got now on your slide, some of your top solutions, I guess, involve funding or money. Have you thought of anything else, or are there other ways that we can strengthen some of the systems and things that we already have in place? Because obviously it was just done at False Bay, but surely we can translate your study in other areas, and some of the findings might also be the same. Can we strengthen things that are already happening in hospitals, or ways to educate patients and parents?
We certainly can. I feel like part of it is strengthening the bond between the health service and the NGOs running the community health workers, the CBS, community-based services. It's strengthening that relationship, that we can get the right sort of messages across. Because just the survey that we did in the community, for example, there's this lost middle where people attend or go to clinic when it's really needed. We go when it's really severe, which is good and right, and we go, he's been coughing for half a day, he's been coughing for a day, and there's no there's sort of a lost middle. Either people go too early or too late, and so there is definitely a health education thing that needs to happen, a health promotion activity, and I suppose there's a sense in which that needs to happen with every patient at every visit. But it would be great to get other partners involved. It'd be great to get some sort of media campaign out. One of our recommendations was simply printing a sticker or writing on the front of the Road to Health booklet, phone the ambulance. This is the number, it's 112. Everyone seems to know the American number from the movies. So are we feeding back to, or I don't even know how to, feeding back to our own media industry that people need to know the South African number. People need to know this 112, it exists, and people can get hold of emergency services that way. So I think, yes, it would be great to have more money. It'd be great to have that sort of aspect of strengthening healthcare services. And yes, I think it probably is applicable to the rest of Cape Town, but it is also interesting to note that, and it's more in the introduction of the study, but that the southern sub-district has the highest childhood mortality within the city of Cape Town. And so there is also within Southern, which is larger than the far south, within Southern, there is also something that's happening that's maybe not happening, or at least not happening in the far south, that is happening in other areas, because the childhood mortality rate is higher there than in Mitchell's Plain. The childhood mortality rate is higher there than, yeah, in Western, for example. And so there are, yeah, I don't know. I don't, again, know a good answer, but that engagement with the community health workers and encouraging them to be doing the right sort of messaging within that area and really integrating them into the communities, at least they are in the communities, but that people recognize the value of their services also, I think is one of the ways we need to strengthen that.
Thanks, Luke. I'm going to just go to Leonard. And before I take Leonard's question, I just want to remind people that whoever needs CPD points, can you please email your MP number and your name to Jeroen Swart? Jeroen's email is in the chat. Thanks. Leonard, do you want to ask?
Yes.
Unmute and ask your question.
Yes, I'll ask. Morning, Luke, and thanks for your talk. I was listening to it. It's very interesting. I was just wondering, in your study, in your initial study of the responses from patients, right? From the area that, as you said, drained into that particular hospital in Fischhoek. Did you interview staff, healthcare workers at the hospital to try and get a, I don't know what you call it, like a sort of, to just try and gauge their perceptions of patients, for example, as well as perhaps their working conditions and whatever else they would have to say, because they, of course, are part of the whole system. That's my question.
Thank you for your question, Leonard. It's a great question, and I wish we had time to do all the different things that it was one of the things that we considered, but given the large scope of the study, decided that it wasn't possible to do in addition to everything else we were doing. But I hear you, it would have given valuable insight to have the clinician's perspective as well. So yes, that's certainly a limitation of our our study that maybe I hadn't thought of or mentioned in the limitations, but there were certainly informal engagements with them because of working there together with them. So no, not formally, but yes, we've kind of, but I agree, it would be great to add that aspect to the study. It would make it much more comprehensive. As I was reminded multiple times by my wife and by those that were supervising me during the study, you're doing a master's, you're not doing a PhD. And ultimately, each method on its own could probably have been written up as a separate study. But we chose to write it up as an incorporated whole. And so, yeah, there's certainly scope for further research.
Yeah. Luke, it's absolutely not intended as a criticism. I was thinking that in order to arrive, especially to arrive at solutions, practical solutions, it could help to include the entire system, which would include the clinicians. So, but yeah,
So,
that's maybe for another time. You know,
we included them somewhat in the sense that some of the doctors are part of the COPC team. So there is a community-orientated primary care kind of team function where a team of people within the Far South meet together, and that team includes people from public and private. It includes the EMS services, some of the doctors from the hospital. Ben, who supervised my study, is a pediatrician at Victoria Hospital, and he comes sort of as the outreach pediatrician to that area. So he's kind of included in that COPC structure. And then, yeah, so we aimed our interview or intervention questions there at that group that was already existing, being a multifaceted group within the health and community services.
Thanks, Luke and Lynn. Steve?
Yeah, thanks, Luke, for a really clear presentation. Clint has already alluded to Peter's study, which was his PhD, of a huge study of children admitted to pediatric ICU at Red Cross. So they'd been through various levels of the system before they got to the tertiary stroke quaternary level. And I just wanted to share, you said this was...
So, I certainly read that study more than once and have quoted it within the work that I did. So yes, it's a very, very helpful study. We kind of, I suppose, in part took that, but also wanted to look at it from the other perspective, what's happening from community and at primary healthcare level, rather than the top down from Red Cross.
I wanted to share these just for comparative data. This is also qualitative care, 43 respondents. And this step of deciding to seek help, like what happens at home, is this serious, is this not serious? How are those decisions made by the parents or the caregivers? Who has to give permission to actually spend money and hire a taxi, or, how there are nuances to those decisions that are crucial in making the difference between, too late, late presentations, etc. There was a big component in that study on EMS, which Clint can speak to, and certainly Peter went into a lot of detail. But it's interesting to see this, your themes in contrast, and you have quantified them. These are not prioritized in any way, but it did seem that this step of deciding that this is serious enough to actually get help for is one of the most crucial. And people are at, as you say, they're at sea. Like, you know, is this cough that's been going on maybe for 7 days? Is this serious? Well, we would probably say, yeah, it's quite serious. You should get help. But, you know, if everyone else is coughing, well, no, you know, how do those decisions get made? Who makes those decisions? Seems to me a very nuanced and crucial set of issues to understand, more probably by an anthropologist than by a, you know, medical person sitting at a hospital.
Yes, I completely agree, and there looks like there's a lot of congruency in those topics. So, I mean, you know, one person that was interviewed, the child is with another caregiver because they work. They're fortunate to have work, but they work, and the work requires them to work 7 days a week. And so the child is with an additional caregiver. So what needs to happen is that caregiver has to recognize that there's something wrong. They phone the mother, who then goes to speak to the boss to say, I'm worried about my child. I need to leave work. And the mother then travels to get to the child and take the child to the healthcare service. So there certainly are quotes that support that theme of decision-making and how decision-making is made, although we didn't draw it out as a specific theme. But yeah, it's definitely there, and the cost things and what happens, and so that came out in both the surveys that we did, the qualitative questions within the community survey, and it also came out within some of the interviews. So yeah, I suppose could have been highlighted, but it again kind of speaks to what we've said in our recommendations in terms of knowledge transfer and community health workers being involved with that.
Yeah, and I must just add that the NGO working in that area is one of the better ones that employs the community health workers. So it is, what Dave said is really significant, you know, that it didn't come up spontaneously, that, you know, oh, well, I spoke to the community health worker and she said, you know, I must do this or this. So, yeah.
So, I mean, there are certainly limitations within our study. We did 62 community surveys. So that doesn't mean we would have got to everyone. We tried to divide up the area geographically. We tried to encourage the research assistants who were helping with that to find people who were of different social standing, of different languages. And the survey that we created, we translated into Shona and Chichewa and
Chichewa.
and Xhosa and Afrikaans and English. So the survey was available in a number of different languages, but and then again, the interviews that we had, we were able to do 11 interviews. Some people were not contactable, and we put that in our limitations because potentially the people who are now not contactable a year after their child died, maybe they have more issues and more barriers than people who we can contact. And so, I mean, well, we started off with a relatively large cohort or group of people that were eligible for interview, but because of their child having been triaged either red code or blue code, but ended up kind of simultaneously reaching saturation and having, well, the next person that was supposed to come for the interview didn't pitch. So there were 8 or so who scheduled an interview and then didn't pitch on the day. And and others who refused and others who were not contactable. So, I mean, that detail is in the study, but it certainly does speak to some of the limitations of such a study. And while we get a broad scope and a broad picture of what is happening, yeah, I mean, even as Samantha has asked, how do we then apply this to other areas within Cape Town? And certainly more work is probably needed. But it would be nice to have work that's sort of practically focused. So could we give these community health workers in this area an X intervention and follow it longitudinally in comparison to a different cohort that are not doing an additional intervention and see if there's any difference? I don't know, it's just an idea for...
That's the community first aid responders idea.
That's one of them, yeah.
Yeah. Thanks.
Thanks, Steve. Thanks, Luke. I see we're coming to the end of an hour. And Luke, obviously you can see that your talk has generated quite a lot of discussion. And I think also raised some, I mean, you keep referring it to as limitations, but I'm not seeing it as limitations. I'm seeing it as opportunities for ongoing research in this area. The role of CHWs, the relationship with the formal health sector and people's perceptions, kind of early recognition of serious illness. There's a whole lot of questions that one could start formulating, I think, around some of the issues that you brought up. I'm gonna pass around for the last round of questions or comments. We'll last 2 minutes. And then just a reminder once again for CPD points to email Jerun, whose email address is in the chat. Okay, so not quite 2 minutes, but if there are no more questions, thank you very much, Luke, for sharing a very, very interesting and important study. Thank you, colleagues, for taking your time out for joining us. And Sharon, I believe this talk will be uploaded onto our YouTube channel.
Yes, Klaus will do that. And so thank you, Luke, and thank you, Taslim, for hosting. And Klaus will process the video as always and put it online. Thank you, Klaus, for doing that. I think he had to go, but he will process it once he gets there.
Great. Thank you very much.
Thank you, everybody.
Bye-bye.